Hey folks, welcome to the AABIP podcast. This is Samir Avasarala from Case Western Reserve University School of Medicine in Cleveland, Ohio. I'm your host for today's episode. Thank you for joining us. It'll be an excellent discussion about a topic that has wide practice variability, post-airway stenting management. Today, we are very fortunate to have Dr. Jose de Cardenas, also known as Pepe. Pepe is an associate professor of medicine and thoracic surgery at the University of Michigan and the director of their interventional pulmonology program. Welcome, Pepe.
Thank you for inviting me. I'm very excited to talk to you guys about this.
Excellent. Pepe, do you have any relevant conflicts of interest to disclose?
Not related to this topic.
As a reminder, the views expressed on this podcast are those of the speaker and mine and not necessarily endorsed by the AABIP. With the formalities done, let's get started. So, airway stenting is one of the most satisfying procedures that we do as interventional pulmonologists. In the right patient, it's a pathway for immediate relief of their dyspnea. As exciting as stenting is, post-stenting management is very, very important. And we all know that practice patterns vary significantly. It's important to know what people are doing out there. So Pepe, what is your typical post-stent management plan?
So I think that when we talk, or even before considering post-stent management, we have to talk about the pre-management. And that starts basically with, as you said, the correct patient selection, also discussing what are the goals of the stent, and also ensuring that you're going to have a good regimen and a plan for follow-up, because no matter how much you can think about a post-stent management, if you don't discuss that with the patient, right, that's not going to happen. So my usual modus operandi for all our group here is that if a stent is deployed, right, we obviously discuss that with the patient, goals and follow-up. But once we deploy it intraoperatively, we communicate immediately with medical and radiation oncology to ensure that the patient gets the treatment that he or she requires. So this is very important, especially if the patient is naive to therapy, or also if there is to evaluate if there is any other new regimen for chemo radiation that the patient might require. I consider the majority of our stents are bridge to therapy, right? And being therapy, either surgery, surgery, radiation, or chemotherapy. And after that is established, and again, we have a really good communication with our colleagues, we set up a follow-up in clinic, in the outpatient clinic, with usually a CAT scan that most of the time is without contrast. And then during that visit, right, we ask ourselves, is the stent still needed, right? And does it have any complications related to the stent, right? Sure. And if so, we usually, depending, again, this is a discussion with the patient, we perform also in the majority of cases bronchoscopies to review those stents at 1 month. And if everything is fine, we repeat that 2 months after, meaning 3 months after the stent has been deployed, and then another one at 6 months, and then 1 year, right? I think that the pre-operative or the pre-management is super important, because we also take advantage of this timing before going into the procedure, because we would like to set up and teach the patient not only about the importance of follow-up, but also ensuring that he has all the resources necessary to avoid complications, right? So we have, for example, in our program, we have a clinical specialist who is our respiratory therapist, who ensures that the patient knows how to use the nebulizers, the flutter valve, right, and all those drugs. So it's a good setup.
That's excellent, Pepe. I think you've really emphasized two important points in interventional pulmonary, especially when it comes to stenting. One of them is, especially in malignant disease, generally the stents we place should be viewed as something that's bridging to actual therapy for the cancer is done, whether that's radiation, chemo, in rare instances, surgery, or a combination of the others. And also emphasize that us taking care of patients in the setting of stenting, you also mentioned communication with your radiation oncologist and oncologists about it's a very team-centered approach to make sure the patient has the best outcome. What medications do you kind of tell your patients to use after a stent's placed?
So we have initially during fellowship, I learned, and I think the majority of us learned to use a combination between mucolytics, mucokinetics, right, and expectorants. But there was a nice study many years ago by a fellow in Boston called, his last name was Odell. That was, I think, an abstract in 2010 that showed that patients with a airway stent regimen, who had the airway stent regimen started right after the stent, had 9% of complications. The majority of them were mucus plugging, right? And those who did not have had 40% of mucus plugging, which is a lot. It's 4 times, right? So I think that highlights the importance of airway stent regimen, right? And even before going into the medications that you can use, I think it's very important, and this is very simple to remember, right? There is, I don't know if you have heard about the bottle of ketchup paradox, which actually resembles the importance of the mucus volume and the cough effectiveness, right? So the ketchup bottle is easier to emptier if actually with just a palm slap, if you have a big amount of ketchup, and it's very difficult to get the ketchup out if you have just a little bit. So, and that means that you really want to have a lot of volume of mucus. You want to have a very hydrated mucus, and as well as very thin. And that can be achieved with basically 4 main classes of mucoactive drugs, right? The first one is expectorants. The other one is mucolytics, so meaning those that decrease mucus viscosity. Mucokinetics, so medications that can increase the ciliary beat frequency and mucus regulators. I think the key, we did a lot of trial using 3% or even regular normal saline during fellowship. But I think one of the key components of our stent regimen is albuterol. And not only because there is a lot of papers, and I think the greatest review I think about beta-agonist and mucus is actually published by Dr. Salafi in 2002, which is available in PubMed. But albuterol does not only increases the ciliary beat frequency, but also hydrates the mucus because it affects ion transport channels. So you have more water in the airway that is going to increase the volume. And also does not only have these 2 effects, also reduces the damage that you can have during infection and potentiate secretions of certain cytokines. And all this is described in this nice paper that actually decreases inflammation, right? I think the other component that we use, which I use it routinely as well, so is guaifenesin. And guaifenesin is going to increase the hydration of the mucus that you have, and it's going to decrease the viscosity. So it's going to basically reduce the sputum surface tension, and it's going to increase the mucociliary clearance. There is a nice paper again in 2019 by Dr. Ohan. And I reserve, so those are usually albuterol, usually nebulizers, no the pump, no MDIs. And albuterol, I put it basically around twice a day, standing fashion, as well as guaifenesin, 1,200 milligrams PO/BID, right? I usually reserve N-acetylcysteine, and I use N-acetylcysteine 20%, 5 mL, also as nebulizer. And just remember that N-acetylcysteine can produce sometimes bronchoconstriction. So it's important that the patient and their family members remember that you have to use the albuterol, followed by the N-acetylcysteine immediately, and then add the flutter valve. N-acetylcysteine is a very interesting drug because it's not only gonna dissociate make it thinner, the mucus, but also it has been associated with a reduction of airway bacterial load, right? And apparently it's because it reduces the ability of the bacteria to adhere to epithelial cells. And again, this is to be defined if this has some value in airway stenting, but potentially it could reduce the stent colonization that you might have. Flutter valve are very important, right? So that also is part of our regimen. And I tend not to use saline 3%, right? Because it only increases by increasing the amount of volume of the mucus, but it doesn't have any other effects. We tried before, but we saw more complications, although this is anecdotal.
Sure. So, Pepe, just for myself and our listeners, just to make sure that I got this correctly, it seems it's a 4-prong approach with albuterol, NAC, and you're going to use Mucinex and a flutter valve. Is that correct?
That is correct.
Okay, great. So my assumption is the answer is no, but do you modify your plan based on the type of stent you place?
I tend to be more aggressive with bone stents, actually, because in terms of not only with the regimen, but also in terms of a follow-up. And the reason is because, I love bone stents. I think they have a very important role, but I think they tend to be a short-term stents for us, or an emergency stents, right? Because of the issues of fractures and ingrowth of the tumor. So I tend to bring them earlier, or trying making sure that I don't miss them, or those patients don't miss the follow-up. And also I'm very OCD when I have patients who have a marked inflammatory airway response. So,
sure.
For example, those patients with post-intubation tracheal stenosis or subglottic stenosis that you put a stent, you know that it's going to granulate, right? I want to bring them a 4 weeks bronchoscopy for sure, right? Or even 2 weeks after, right? And making sure sometimes I increase the albuterol and the other nebulizers as well to 3 times a day, right? I usually reserve because of the inability. Has been a shortage of N-acetylcysteine. I tend to limit that to as a last resort. So only when the patient needs it. I usually start just with albuterol, albuterol and guaifenesin, right, with the flutter valve. And then if the patient has any problem, I add NAC.
Got it. So it sounds like it's a bit of a step-up therapy, if you would have.
Yes.
Is that correct? Okay.
That is correct.
Okay. So, and I think, Pepe, you mentioned something that I want to talk to you about bringing patients back post-stenting for a bronchoscopy, whether they're feeling great or whether they're expressing some sort of symptoms. What is your general thoughts of post-stenting 4 week, 6 weeks bronchoscopy? Is it something you're doing standard for everyone, or a certain selection of patients? Or are you depending on their CT scan?
I think it has a very important role. So there is a nice paper that I think the majority of us are very familiar, published by Dr. Hans Lee in the Journal of Thoracic Disease in 2017. So that showed that actually the majority of patients were not symptomatic at all when they had the stent complications, and there was no association with the indication of stenting or the location of the stent with complications, and it was overall safe, right? So what I don't bring the patient to look and do a bronch immediately, right? But I bring the patient in clinic first to examine them, to discuss with the patient, and overall see the whole case, how the patient is doing, right? So it would be, I think, absurd to bring a patient for a bronchoscopy when they're on hospice, right? If they are not responding to therapy and they have worsening performance status, right? And if there is no evidence of CAT scan, or there is at all no airways of symptoms, or there is no response to treatment, right? You know that you have to discuss, does a bronchoscopy is really needed or not, right? So if the patient is having any complication, is able to tolerate the procedure, right? So I think it's a discussion. It's not, I think, cut and paste or approach, right? It has to be decided, but in the majority of our cases, we bring them for bronchoscopy, and again, it depends on each patient.
Yeah, I hear what you're saying. It's rare that a one size fits all approach
Yeah.
is applicable to our world. So I always view airway stenting as an excellent example of a mix of art and science. Keeping this in mind, how did you come up with your post-stent management plan? Is it something that you learned in fellowship and you stuck with it, or you modified it as you kind of built your own career?
Yeah, I I think I was initiated on this by my mentors in Boston. But even then, we were we were challenged because the data all there for airway stenting management is at best very ambiguous,
Mm-hmm.
right? So we did trials of internal trials with normal saline, with 3%, right, with albuterol, and we noticed that albuterol anecdotically work best. And it's not only because it's gonna again, that albuterol nebulization is going to hydrate the stent. But again, remember that the majority of our patients also suffer of COPD or asthma, or they don't have really good pulmonary function or pulmonary parenchyma reserve, right? So I think it helps, right? So we started with albuterol. I remember my mentor, Dr. Majid, we were using smaller doses of guaifenesin. So we ramp it up to the max dose allowed, which is 2,400 milligrams once a day. So we are using just routinely 1,200 milligrams.
Okay.
Right. And I think that the flutter valve is super important. And I think this is key because, again, no matter how much mucus you're going to produce or how much you're going to have, if you don't, it's sometimes it's going to be very thick sometimes. So you need some help to mobilize it. And the funny thing is that some patients, that our patients are very familiar in the majority of cases, especially if they have undergone surgery before, with incentive spirometry. So knowing the devices, right, is very important. They're going to say, oh, yes, I'm doing my flutter valve. And actually, they're not doing the flutter valve.
Sure.
They're using the incentive spirometry instead, which is not going to help. It will prevent atelectasis, but you need to cough them up. In debilitated patients or patients who are in the ICU, we use chest vest, right? And what I do as well to avoid migration, and I think this is a common practice for among all of us, although we haven't studied it yet, is that I tend to dilate my stents immediately after deployment.
Yeah.
Right. So ensuring that they're very well tucked in within the airways. So the migrations that I have had in the last 7-8 years are, I think maybe I can 1 or 2, right? But that helps also a lot.
Excellent. So, Pepe, one of the questions I always ask myself when I'm doing a bronchoscopy on a patient and I know a stent is needed is, when I'm placing the stent, one of the questions that's always in the back of my head is, when can I get the stent out? Because I think that's very important to kind of plan ahead, or at least have some sort of thought process about what does the patient need next, about that would affect when I can get this out. So what do you keep in mind when deciding when a stent can come out?
Yeah, so I think that the main indicator, right, is there are going to be 3 things that you're going to be thinking. Has the patient responded to the oncological treatment, right? So, because again, if there is a big mass producing external compression, yes, the stent is needed still, right? And you might need to change it sooner if, for example, it's a bone stent, right? The other thing that so the response of the oncological treatment, great. So if the patient has responded completely, right? Yeah, you don't need it. We're going to remove it, right? Then the other question that I am also asking, and again, this is important, and this is something addressed in the outpatient visits, is asking the patient, are you having any complications related to the stent, right? So there are patients who are not gonna be able to tolerate the stent at all, right? Especially those with TBM, right? There are gonna be some patients who have granulation tissue, then you need to change them, right? There are going to be patients who have cancer and they're going to have infections. So if they're having complications, yeah, we might need it, or you might require, again, what we quote, especially for benign disease, this is what I do, a stent vacation, right? And when I also, I think that one of the most important factors is also, can the patient tolerate the procedure for removal, right?
Sure.
And this is, and I think the timing is also super relevant, because I have had some cases where we're all eager to remove the stent and the patient is doing fine and she just completed radiation, right? And if you will find that once the patient has had radiation, and again, this is anecdotal, if you remove it within the week after finishing radiation, everything is going to be very friable, right? So I let it cool down, and I let it cool down for around 2 or 3 weeks after finishing radiation, in order to avoid that problems with hemoptysis as well.
So within the last, what's going on 2 years now, we've had the unique experience of working our way through this COVID-19 pandemic with a lot of supply chain shortages, et cetera. So in this era of drug and medical equipment shortages, and you briefly talked about this earlier, did you have any backup plans to resort for post-stent management if your typical regimen is out of stock or on back order?
So one of the good things is that our stent regimen is what we call the 3 Bs in Spanish: bueno, bonito, and barato. So meaning they are good, they are bonito, so meaning they are very easily accessible, and they're very cheap, right? So bueno, bonito, and barato. So and albuterol is, you're not going to find a shortage of albuterol or guaifenesin. Neither flutter valves, and you can buy those in Amazon. However, what we have had issues is actually with N-acetylcysteine, right? And N-acetylcysteine, I'm like very impressed by its effectiveness. You will not find in the majority of cases that being distributed or in your regular local pharmacy, but you are working in any institution, they mostly will have it, right? But sometimes still we are short of that. So what we do is tend to, if the patient really needs it, we give it to them, or we know that the patient is going to produce a lot of mucus, we ensure that they have it before they're being discharged, right? So we tend to do that. I'm a little bit, I think the majority of us are, we're very OCD in terms of before the patient being discharged with a stent, ensuring that they have absolutely all the resources, all the equipment, right, that they have been taught, and also follow up. I think that's critical. And I think that we start also with this, in this era of shortages, right? It's like, do you really need to put an stent, right? Is this a patient with a small cell that in 1 week or 10 days, if they start therapy, it can be resolved, right? So I think that's very important. So you can avoid putting a stent, amazing, right? But if you have to bite the bullet, then you have to.
Do your patients go home with some sort of stent card or stent bracelet or anything like that?
No, actually. But we have our team that calls the patient the next day, right? And they have full access to our team. We don't send them with cards except when they are, for example, because the majority of them stay here in our institution, except though when they go with large stents, with wide silicone stents or high tracheal stents.
Sure.
I think that in those cases it's super important, in case that they end up in the emergency requiring an intubation. I think it's critical to put a note there, right? How this patient his airway can be accessed, or her airway can be accessed. We usually print the reports, right? So of those patients, so the patients actually have pictures of their stents. So we like to document a lot with pictures, and that's basically how they are discharged. And again, the follow-up, we bug them a lot to ensure that they are not missed, right? Or they're not lost in our system.
Yeah, it sounds like a very pragmatic approach. So time for closing remarks. Anything we left out that you feel is important to discuss?
Yeah, I think one of our colleagues who is joining us soon in this July 2023, Max Wayne, did a survey among thoracic surgeons and IP, and basically, yeah, as you mentioned, right, there is a lot of variety of how we treat stents. Around 3/4 prescribe at least of one medication of more than 140 patients, right? And only half of them perform routinely bronchoscopy, even in asymptomatic patients. So I think this paper is gonna show us that, again, the variety that we have in airway stent regimen, and maybe shed some light on how we can improve or even put some background in order for us to really design a multi-center study. So, and just to close up, right, I think that when you care for patients, I think that also implies that you care for the stent that you place, right? Mm-hmm. So you have to choosely wise when it's needed, right? You have to build a support system for your patient, right? And its follow-up. And I think that, again, although there is not a lot of data that support airway stent regimen, there is a lot of regimens that we can use extrapolating the data from CF patients with bronchiectasis that can help us to manage those patients and avoid complications.
Yeah, I look forward to reading that paper with the results that Max is going to put out there. Very important questions. I remember taking the survey some months ago, so eagerly anticipating those results to be out.
Yep.
Pepe, I really appreciate your time. Myself and our listeners surely learned a lot about stent management and some of the dynamics of a ketchup bottle, which I never thought we would address on one of these podcasts. So thank you for your expertise and time.
Yeah, thank you. You can use a mayonnaise bottle too, so don't worry. It's the same concept.
There we go. We're just racking up sponsors. I appreciate it.
All right. Take care, my friend.
Take care, Pepe.
Bye-bye.